Welcome back. Let's talk about the bundle branch blocks. Right bundle branch block. The presence of an RS-R' pattern in lead V1 or V2 indicates the presence of a right bundle branch block. This is due to the damage of the right bundle branch, which usually depolarizes the right ventricle. However, right bundle branch block is also a normal variant in many people in the population. The QRS or RSR complex is longer than 100 milliseconds or 2.5 small squares. The left bundle branch is normal as an electrical impulse passes down the atrioventricular node, then down into the bundle of His. It enters the bundle and the interventricular septum is depolarized normally from left to right. The vector of this depolarization is towards leads V1 and V2, and it gives a small positive deflection called the R wave. Then the depolarization spreads to the left ventricle, away from V1 and V2, and there is a large downward deflection called an S wave. Finally, the right ventricle depolarizes, and it's the last to do so, and it depolarizes towards V1 and V2, and there's another positive wave. It's not just an R wave, we call it the R' wave, moving towards V1 and V2. This overall RSR pattern is sometimes referred to as the M complex, and a reciprocal shape, that is an inverted M, is seen over the left ventricular leads. A stable, isolated right bundle branch block is of no great significance because the entire ventricle can be depolarized from the left bundle. The position of the right bundle on the right ventricular endocardial surface of the ventricular septum sometimes makes it uniquely susceptible to damage. Now, the possibility of causing a new onset of right bundle branch block may be very worrying in certain circumstances. If you are floating a pulmonary artery catheter and as it passes through the right ventricle, if it hits the interventricular septum, it can cause a new right bundle branch block. But in a patient with a pre-existing left bundle branch block, you're going to find that your patient is suddenly in complete heart block. New onset right bundle branch block may indicate progressive conducting system disease, and this may have a tendency to also involve the left bundle, and again the situation could deteriorate into complete heart block. Sudden onset of right bundle branch block and tachycardia in the presence of an undiagnosed acute cardiopulmonary illness suggests pulmonary embolism, especially if there is marked right axis deviation and a picture of right ventricular strain. If a patient with a pre-existing right bundle branch block develops an SVT, it looks extremely similar to ventricular tachycardia, and the distinction between the two can be difficult. This is termed SVT with aberrant ventricular conduction or SVT with aberrancy, and distinguishing it from ventricular tachycardia requires expertise. Essentially, if you can get a 12 lead and show that there's no change in the mean frontal QRS axis in a wide complex tachycardia, you're probably dealing with SVT with aberrancy. But if there's a marked change in the mean frontal QRS axis, you're probably dealing with ventricular tachycardia. Now let's talk about left bundle branch block. With a left bundle branch block, the entire ventricle depolarizes from the right bundle. This gives a typical RSR pattern or M complex over the left ventricular leads V4, V5 and V6, with a reciprocal pattern, an inverted M, in the right-sided leads V1 and V2. The QRS or the RSR complex is longer than 100 milliseconds, again of course, that's greater than 2.5 small squares. Left bundle branch block has many possible causes. Some are relatively benign and others are sinister. It can occur in hypertension, hypertensive heart disease, left ventricular hypertrophy, or it may be idiopathic, that is no obvious cause. Left bundle branch block may develop acutely due to myocardial ischemia or infarction, or it may be chronic as a result of myocardial fibrosis or scar formation long after myocardial infarction. In advanced cardiac life support, one of the presentations of an acute coronary syndrome may be the new onset of a left bundle branch block. And of course, if this is the case, then it's going to be extremely difficult to interpret any decreases or increases in the ST segments. So watch out for new onset of left bundle branch block. It can be sinister. It is sinister when it occurs in a patient with congestive heart failure or cardiomyopathy. It indicates chronic structural damage and stretching of the left ventricle, usually due to severe dilatation of the cavity or even fibrosis within the ventricular walls. The combination of left bundle branch block and chronic stable angina is often associated with a very high incidence of severe left main coronary artery disease. A recent onset of left bundle branch block should lead to a search for cardiovascular disease, especially those causing myocardial damage. A new onset of left bundle branch block in the context of chest pain is, as we mentioned, an acute coronary syndrome and should be treated as per your advanced cardiac life support algorithms. Further, left bundle branch block is usually well tolerated as long as there is no other conducting system disease. Coexisting conducting system findings which should raise concern are a first or second degree heart block associated with LBB. There may occasionally be progression to complete heart block, and this is very worrying. However, if previous EKGs indicate that the conducting system has been stable and the patient has no symptoms to suggest episodes of loss of cardiac output, such as Stokes-Adams attacks, then the chances of complete heart block are minimal. There is a phenomena of normal QRS morphology at normal heart rates, but at high heart rates, the ventricular activation pattern adopts a bundle branch block morphology. This is called rate-dependent left bundle branch block. Again, episodes of tachycardia with left bundle branch block, such as SVT, present a diagnostic confusion with ventricular tachycardia, and in these cases, a sudden change in QRS axis and an irregular R2R interval are suggestive of ventricular tachycardia. A very regular R2R interval with no change in mean frontal axis strongly suggestive that the pattern of depolarization through the ventricles is unchanged, and SVT with aberrancy is much more likely. Refer to the SVT with aberrancy versus ventricular tachycardia checklist. Now let's talk about complete heart block. In this condition, the atria and the ventricles are electrically disconnected or insulated from each other. In complete heart block, the atrial contractions continue with completely normal P waves. The subordinate pacemaker foci in the ventricles are released from suppression by foci higher in the hierarchy, and an idioventricular rhythm appears. The key to the diagnosis of this rhythm is to note that the P waves and the QRS complexes are completely unrelated to each other in timing. A useful trick is to take a strip of paper and mark the positions of all the P waves on this piece of paper. Then take a second strip of paper and mark the position of all the QRS complexes, and then attempt to superimpose one strip on the other to see if the P waves and the R waves bear a constant relationship to each other. Complete heart block indicates the presence of serious cardiac disease. It may be primary failure of the conducting system, but it is more likely to be secondary to ischemic heart disease, or cardiomyopathy, or even myocarditis. Occasionally, complete heart block will recover, but temporary external pacemaking will still be required. In some cases, the heart block is permanent, and a permanent pacemaker must be implanted. In some cases, the patient's blood pressure and cardiac output will be adequate for a time, but in many circumstances in complete heart block, they are inadequate and intervention must be immediate. The treatment is initially boluses of atropine, or as an infusion of dopamine or epinephrine as per ACLS protocols for adult bradycardia. Isoproterenol, that is isoprenolone, has also been used in the past, but it's perhaps a very poor choice for a patient if you think they have significant coronary artery disease. Treatment with positive chronotropic drugs is always a temporizing measure, while arrangements are being made for temporary pacing. But this too is a temporizing measure, while arrangements will often need to be made for implantation of a permanent pacemaker. Transcutaneous Zoll pacing is now widely available and is very helpful in the short term. A commonly available alternative is temporary transvenous ventricular pacing. Transesophageal atrial pacing is suitable only for a minority of patients already sedated or intubated. The best available temporary option remains ventricular pacing using a wire placed through the internal jugular vein into the apex of the right ventricle. Electronic pacing in this manner can actually produce a pattern of ventricular depolarization which mimics a bundle branch block. Now, the management of transcutaneous pacing for a patient in a severe bradycardia has already been considered in one of our early videos in this section on arrhythmias. So please refer to that for further details so you can be prepared to act if somebody develops complete heart block acutely and you need to treat it. So please refer to that video, because you never know when one of your patients is going to suddenly enter complete heart block and will need emergency and rapid treatment. Thank you. Welcome back. Let's talk about the basis of the re-entry phenomena. Atrial fibrillation, atrial flutter, atrioventricular nodal re-entry tachycardia, that's AVNRT, and atrioventricular re-entry tachycardia, AVRT, due to a bypass tract or ventricular tachycardia in the context of myocardial infarction and even ventricular fibrillation, are all caused by a re-entry mechanism. So clearly, this is a very important subject. Normal ventricular activation commences in the atrioventricular node and terminates in the ventricular myocytes. A re-entry arrhythmia is due to a descending electrical depolarization being diverted away from its normal pathway to enter an alternative pathway which travels retrogradely and stimulates the descending pathway. Return of the depolarization explains the term circus, and circus means a ring and is commonly referred to as a circuit. This circus movement can become self-perpetuating with the abnormal excitation presenting one of several types of paroxysmal tachycardia. What are the requirements for a re-entry circuit? Normal conducting tissue in the heart can conduct impulses both antegrade and retrograde. The existence of re-entry requires the following prerequisites: a region of myocardium which can conduct an impulse in only one direction, and the conduction in this direction is slowed. The arrival of the retrograde impulse at a region of normal conducting tissue must find it in a receptive, that is, an excitable state. This depends on the length of the effective refractory period in normal tissue, which implies very precise timing of the retrograde excitation. Patients may develop discrete episodes of supraventricular tachycardia presenting as paroxysmal SVT, and PSVT, paroxysmal SVT, is common in hospital medicine. These patients often present with an acute onset and occasionally an abrupt termination of palpitations, dizziness, unexplained breathlessness, sometimes fullness or pressure or pain in the chest, sometimes in the neck, and the palpitations can physically cause throat discomfort. There are two main types of re-entry phenomena: atrioventricular reentrant tachycardia, AVRT, and atrioventricular nodal reentrant tachycardia, AVNRT. Syncopal episodes may occur in AVRT, but they are very uncommon in AVNRT. Many episodes last for hours. Some may only last for a few minutes. Sometimes they persist for days. The most common cause of paroxysmal SVT is atrioventricular nodal reentrant tachycardia, AVNRT, and this represents 60 to 70% of paroxysmal SVTs. AVNRT is a narrow complex tachycardia at a rate of approximately 160 beats per minute. It affects twice as many women as men, usually the young in the first 2 decades of life. There may be 2 peaks, one in the teens and another in the early 30s. Let's talk about anatomically based and functionally based re-entry. There are 2 main groupings of re-entry arrhythmias: anatomical and functional causes of re-entry. Anatomically based has a fixed anatomic pathway allowing abnormal conduction. These are sometimes termed accessory pathways or bypass tracts or pre-excitation tracts, such as the bundle of Kent in Wolff-Parkinson-White syndrome, and they connect the epicardial surface of the atrium and the ventricle along the atrioventricular groove. Up to 90% of these have paroxysmal SVT due to an AVRT, and 10% are due to AVNRT. Local and global re-entry circuits in the heart. Re-entry mechanisms can be based on micro or macro circuits. In Wolff-Parkinson-White syndrome, there is an accessory pathway which travels from the atria to the ventricles, bypassing the atrioventricular node. This depolarization spreads through the ventricles and then enters the bundle of His and travels retrogradely back through the AV node, back to the atria, and it re-excites the atria. This circuit includes the entire ventricle and possibly the entire atria, so it is an example of a macro or global re-entry AVRT circuit. Functionally based re-entry implies the absence of a discrete or anatomically defined bypass tract or any recognizable accessory pathway. These are often micro or local re-entry circuits restricted to a small region of the atrium, the AV node, or the ventricle. Often there is one, but occasionally multiple, functional mini re-entry circuits between the atria and the ventricles. Ventricular tachycardia is often a re-entry arrhythmia. The evolution of ventricular tachycardia into ventricular fibrillation can be conceptualized as being caused by many thousands of mini re-entry circuits spontaneously established within the ventricular myocardium and gradually degrading from VTach to VFib. As mentioned in the previous video, the atrioventricular node has two pathways. Usually they are both descending pathways, called a fast pathway and a slow pathway, which converge on the bundle of His. At the end of the pathways, the fast depolarization will attempt to move upwards, that is retrogradely up the slow pathway, but the two depolarizations will meet and cancel each other out. Consider this sequence of events. Normal depolarization of sinus rhythm reaches both pathways. The fast pathway depolarizes rapidly. Now, a premature atrial contraction occurs. Its depolarization arrives at both pathways. It finds that the fast pathway is refractory, but it travels slowly down the open, slow pathway. At the end of the slow pathway, the depolarization meets the distal fast pathway, whose effective refractory period is now over, and it is now excitable and ready to be stimulated. The slow pathway depolarization depolarizes the distal fast pathway, which conducts the depolarization retrogradely ascending to the atria. This is the slow, fast atrioventricular nodal reentry tachycardia pathway, and it accounts for 80% of reentrant tachycardias. The first descending antegrade depolarization may initially take the fast but longer pathway, and it arrives at the shorter slow pathway when the slow pathway is excitable and the slow pathway conducts up the bundle of His back to the atria. This is the fast-slow atrioventricular nodal reentrant tachycardia pathway, which accounts for only 10% of reentrant tachycardias. Now consider this. The initial antegrade depolarization takes the slow descending pathway. Now a second slow pathway exists through the left atrial myocytes. When the descending slow pathway reaches the excitable left atrial myocytes, they conduct the impulses retrogradely back to the atria. This is called the slow atrioventricular nodal reentry pathway, which accounts for only 1 to 4% of reentrant tachycardias. Now, clinical features on the EKG. In orthodromic AVRT, the ECG shows a narrow complex tachycardia at 200 to 300 beats per minute. In the antidromic AVRT, the QRS is a wide complex at the same rate. In AV nodal reentrant tachycardia, this is narrow complex at 180 to 250 beats per minute. The P wave may be invisible, hidden within the QRS, but sometimes it occurs immediately after the QRS. If this arrhythmia stops spontaneously in a QRS complex, then it terminated in the fast pathway. If adenosine is used or if carotid sinus massage is applied and the arrhythmia stops with a retrograde P wave, then it terminated while in the slow pathway. Carotid sinus massage or beta blockers, calcium channel blockers, or synchronized cardioversion can terminate an individual attack. Prevention of future episodes is more challenging. A good quality randomized 2017 trial of prevention of future episodes of AV-NRT compared medications, a beta blocker bisoprolol or a calcium channel blocker diltiazem versus catheter ablation. Catheter ablation was convincingly proven to be superior. So your patients with re-entry should be considered for electrophysiological ablation procedures, particularly in patients who are refractory to pharmacological treatment. Now let's talk about synchronized cardioversion. SVT, VTach, atrial fibrillation and atrial flutter require synchronized cardioversion, and we will give a very brief account as follows. Apply a cardiac apex chest pad and a right parasternal chest pad. Ensure that the patient's current rhythm appears on the screen of your defibrillator. Select defibrillation mode. The synchronized soft key is now active in the bottom right hand corner of your screen. Press this soft key just below sync on off and the word sync appears clearly on the screen. Down arrows appear directly above the point in the PQRST complex, exactly where the shock will be delivered, which is within the QRS and avoiding the upstroke and peak of the T wave. Select energy level, such as 100 joules. Press charge to 100 joules and this will take a few seconds. Press and hold the shock key. Now of course the defibrillator may appear to delay the delivery of the shock. It is only delayed slightly to avoid the upstroke of the T wave and it will be delivered on the very next QRS. Now, most defibrillators can help with the difficult to diagnose rhythms. If you do not recognize the rhythm and you just don't know if the rhythm should be defibrillated or whether it should be cardioverted, then press Analyze. If there is ventricular fibrillation or ventricular tachycardia, a shock will be advised. Select an energy of 120 joules, press charge, press and hold the shock, wait for up to 10 seconds, a shock will be delivered. This is defibrillation. Now assume you choose cardioversion, that is a synchronized shock. First, we want to make sure that your Zoll defibrillator or equivalent machine can detect the cardiac rhythm, so apply a 3-electrode EKG configuration to left arm, right arm and left hip. Also apply a cardiac apex chest pad and a right parasternal chest pad. Choose monitoring mode and commence monitoring lead 2, which gives a maximum P wave height, and so it's the best choice for rhythm diagnosis. If you're just not sure if there is or is not a T wave, then your defibrillator can decide for you. If in sync mode it defaults, this means it cannot find a T wave and you should cancel sync mode, then press charge, then press and hold shock, and the shock will be delivered immediately. With some forms of ventricular tachycardia, there may be no detectable T waves. If there are no detectable T waves, then your defibrillator machine will default and will refuse to deliver the shock. In this case, cancel sync on. Now, a few words about this entire section on arrhythmia diagnosis. This has been necessarily an incredibly brief introduction to arrhythmias and their management. You know, massive textbooks of cardiology have been devoted to arrhythmia management alone. This has been a brief overview, the briefest of overviews, as an introduction to arrhythmias. Thank you for watching.